details of formulation and dosing of buprenorphine. I think initially we did this several years ago when one of our echo participants really requested, they really wanted something on like the different doses that are available. How do you start someone at home? How do you dose them? And then over especially the last couple of years, we've also sort of included really things around microdosing, just kind of introduction to that. How do you manage patients with who are using kind of high potency synthetic opioids? So it sort of evolved fairly continuously, especially over the last 2 years, this presentation. And I'm sure it's going to continue to evolve, right? As we learn new things, and as as unfortunately kind of these high potency synthetic opioids continue to be prevalent, and as more data around them comes out, I'm sure this is going to continue to change quite a bit. But this is sort of where it stands right now on April 26th of 2022, right? This presentation. And my goal again is to kind of finish this in about 30 minutes or so, so that we have time for a case discussion, which really is the kind of the heart of an echo clinic, right? And that's really where we apply things we know, things we're learning, things we're yet to learn to co-manage essentially a de-identified patient. So as I begin, no financial relations to disclose, other than, of course, the fact that this entire program, this Medications for Opioid Use Disorder ECHO, is being funded by Agency for Healthcare Research and Quality. No industry relations to disclose. And this is what we're going to go over, details of formulation and dosing of buprenorphine, right? Gonna start, actually, I'm going to go right into going with different formulations, then sort of a carryover from an earlier iteration of this presentation is how, kind of the more traditional way of starting someone on buprenorphine if they're starting at home within the comfort of their home, right? And then we're going to start going into sort of some of the ideas around microdosing around fentanyl, and then a little note on withdrawal and detoxification from buprenorphine. So those are the things we'll try to cover. This is a good chart, comes to us courtesy of PCSS, that goes over all the different formulations of buprenorphine that are available, right, to us as clinicians, to our patients. And this is really a reference slide, right? It lists many different ones. But the first important distinction to think about is monoproduct versus combination with naloxone. Right, if you think about the buprenorphine monoproduct, it's available as a monthly injection, right, called the Sublocade injection. There's also a newer formulation that may be hitting the market relatively soon of an injectable buprenorphine that will be available in weekly and monthly formulations in different doses. And that I would imagine that may be available within the next year or so. And this is a good sort of a good option for some of our patients who maybe not be a great candidate for sublingual daily administration of the medicine. It's given once every 4 weeks. There is also an FDA approved implant, which is inserted every 6 months into the upper arm. Interestingly, although it remains FDA approved, it is no longer on the market because there was no market for it, right? No one was opting or selecting to go on the implant, the Probufin implant. Therefore, it's been taken off the market. Regardless, it remains FDA approved. And then what we use, not infrequently, is the sublingual tablets, available both as generics as well as under brand name, that come in 2 and 8 milligram tablets. Important to keep in mind that although they're tablets, they are taken sublingually. And generally, at least in my practice, I tend to use these tablets when individuals are pregnant. So during pregnancies, when I we'll use this in many cases. But for most patients that we treat, we use the combination medicine with naloxone, right? Where a little bit of naloxone is added to the buprenorphine, really as a means to minimize diversion by sort of parenteral misuse. And this comes in films, which are both generic at this point and brand name, comes in tablets, which are generic. There are also brand name tablets. There is also a buccal formulation. So all of these essentially have some combination of buprenorphine with a little bit of naloxone added to it. I can tell you that in my practice, what I'm most likely to use are the generic films, right? Generic sublingual films is what I wind up using because most insurances, at least here in New Mexico, cover them, and they're widely available in pharmacies, relatively speaking. So that's what I wind up using, right? So I think one of the key take-home points we still give is that for most patients, that combination medicine, that's sort of the first choice we can make, should be used for treatment of opioid use disorder, right? Because the risk of diversion is lower, right? So when someone takes the medicine as prescribed sublingually, the naloxone is not really doing very much, right? Or if someone winds up swallowing it, the naloxone is not doing much. But if someone winds up injecting the prescribed medication, that naloxone is very active, very rapidly. And naloxone, remember, is a very potent opioid antagonist. So it will throw the person into withdrawals if they have opioid physiological dependence. So that's a good means to minimize misuse by parenteral use, right? We use the mono product, as I mentioned, in pregnant women or individuals, with documented allergy to naloxone. But for most patients, I wind up using the combination medicine. Then this question comes up, film or tablet. And the reality is that, both are equally efficacious. And at least, kind of in my practice, what I find is that this choice is largely driven by third-party payer consideration. What's available in the pharmacy, what's likely to be covered by the insurance. There's some indication that maybe films dissolve quicker, so might be more convenient to the patient. And films, because they're individually wrapped, may be easier to track if you're doing callbacks, etc. I don't think there is any great data that it leads to significantly reduced diversion, but that's something to keep in mind, right? This is I kind of like this slide because it's comparing this idea of self-administered sublingual formulations versus this monthly injectable formulation, right? This and I like this slide because I think sometimes when I'm speaking with other colleagues, other clinicians, I hear this idea that shouldn't we just have most people on the injectable because you don't have to worry about diversion. I mean, I think the answer is a little bit more nuanced. Certainly one of the big advantages of the injectable formulation is that, there is enhanced compliance. They get it once every 4 weeks, so you don't have to worry about whether or not they're taking it daily. And certainly the diversion risk is lower because the patients are not going home with a medicine and they're not holding on to it. But on the other hand, right, there's clinical experience, at least comparatively speaking, is far less compared to the sublingual formulation. There are also at this point fewer options. Although they're growing, there's still relatively fewer options, doses available. Also, the closed distribution system makes it maybe not so patient-centered, right? If I want to start a patient on this medicine right now, first I have to get the insurance approval, usually takes a prior authorization. Then I need to order the injectable medicine from a specialty pharmacy that's going to be patient-specific. It's going to be stored in my clinic, and then I'm going to administer it, and it's quite costly, right? So I think there are pros and cons to both. On the other hand, while the sublingual formulation has been around for a long time, its relative cost relatively less, there is more experience, it's widely accessible, there is a greater diversion risk, right? So I have used the injectable formulation very selectively in my practice. So for example, we have a couple of patients who were actually at risk if they had the buprenorphine with them. So we had one patient whose parent said, you can't stay in our home, I'll kick you out if you're on this medicine. So the patient was actually facing houselessness. So switching that patient over to the injectable formulation really wound up being a good way to make sure she has that important housing stability. And we've occasionally used it in patients who continue to be at very high risk of diversion or continue to divert their prescribed medication despite putting in place a good monitoring plan. So with that, the next piece I want to go into is sort of an in-home induction or initiation, right? And again, this is sort of a carryover from an earlier presentation. I mean, if you go to the official training, right, or read the official kind of the SAMHSA documents on buprenorphine, they talk about directly observed initiation of buprenorphine in a physician's office, right, before the passage of CARA. But really, as early as 2007, 2008, many of our primary care colleagues were already starting to experiment with home inductions, right, of buprenorphine. And people started tracking it. And there is some good data that really shows us that, home initiation of buprenorphine, where patients are starting the medicine within the comfort of their homes, can be safe, effective, and feasible. This is a good article about 4 years old, 5 years old at this point, right? Of a large N following a 7-year data. that really compared home initiations versus directly observed initiations and found that both are about equally efficacious and safe. And patients prefer the home initiations more because they're doing it within the comfort of their homes. So I can tell you that this has become sort of the norm, right? In most places, including here in New Mexico, where most patients are starting buprenorphine within their homes. But consider, right? I mean, think about this. This is a patient-centered process. There is no one rule that applies to all, but consider doing an observed initiation in some patient groups, right? For example, if patients have a low tolerance, right? Or you're not sure what their tolerance level is, it may be safer to give the initial dose under direct observation. I think patients transitioning from methadone have just such a high rate of precipitated withdrawals that sometimes doing it with observation can just feel more comforting or more safe to everyone. Or if patients have significant cognitive compromise or psychiatric conditions that are not poorly controlled, and you're unsure whether patient will be able to follow the directions to start the medicine at home. Occasionally, we've done an observed initiation if patients are just super anxious about starting buprenorphine. They're not sure which way to go. We might start them in the office, right? Everyone does this a little bit differently. This is sort of the good middle of the road process that I've included here, right? First of all, we teach our patients to wait long enough to start the medicine, right? Kind of the magic numbers that if they're using short-acting opioids, they want to wait at least 12 hours since last use. If they've been using a sustained release opioid formulation, at least 24 hours. And if they've been using methadone, at least 36 or even 48 hours prior to starting buprenorphine. And I tell them to, you don't want to jump the gun. You really want to be feeling lousy. I tell them they should be experiencing different withdrawal symptoms in at least 3 different systems, right? GI, muscles, for example, GI symptoms, and rhinorrhea. And I actually, in my practice, whenever I do a clinical initiation, home initiation, I send them home with a subjective opioid withdrawal scale. That's what this SOW stands for. It's a public domain tool meant to be self-administered. And I tell patients that, you want a target score of at least 17. So you waited long enough, your target score is at 17, then you can go ahead and start dosing buprenorphine, right? And again, I've taken sort of a middle of the road approach here for clinicians who may just be starting out with this, right? I think it's reasonable to say start with a 4 milligram dose and repeat that 4 milligrams every 1 to 3 hours if withdrawals continue, and try to get to, on day 1, to 12 or even 16 milligrams as a target dose. We tell them that if there are any questions, give us a call at the clinic. This is just the SOWS, the subjective opioid withdrawal scale. It's, as you can see, it's a Likert scale that's meant to be self-administered and really hits a lot of the symptoms and signs of opioid withdrawals. Day 2, I tell them to take the total of day 1 dose right in the morning. We have them check in with the clinic on day 2. Usually talk to a nurse. Hey, did everything go well? Are there any questions for one of our providers? Would you like a call back? Would you like to come in? Right? And later in day, they may take additional 4 milligram doses. And again, I think generally we use a 16 milligram as the initial target, and then we may go up from there, right? And day 3, as you can see, is rarely needed because most patients can get to days, sort of 16 milligrams, usually within 2 days. And then some patients may require higher doses. In fact, there is some indication in some of the newer trials, there is a signal that especially likely because people are just coming to us with such a high degree of physiologic dependence now as a result of fentanyl, patients may do better at 24 milligrams early in treatment as opposed to 16. So generally, once they're at 16, I have them hang in there for a few days. If they're still withdrawing or having a lot of cravings, then I would increase it to a target of 24 milligrams, right? This is just the magic numbers, how long to wait that we talked about, right? If patients are transitioning from methadone, this is trickier. You gotta first bring the methadone down to at least 40 milligrams for at least a week. And that process itself may take weeks or even months if someone's at a very high dose. And many patients, unfortunately, cannot tolerate this, right? Then they gotta be off of methadone for at least 36, in my experience, up to 48 hours, during which we give them comfort medications, right, to manage their withdrawal symptoms. And then once they're in sufficient withdrawals, we begin their buprenorphine initiations. I mean, this is when I've seen the most precipitated withdrawals happen, is when patients are transitioning from methadone onto buprenorphine, right? If precipitated withdrawals do happen, I think first of all, patient education is critical, right? Get their consent, talk to them. We know what to do. Don't run out of here. And if they happen, we treat them simply by providing more buprenorphine, plus or minus comfort medication, right? So withdrawal is withdrawal is withdrawal. If patients go into precipitated withdrawals, providing them more buprenorphine, allowing that buprenorphine to saturate onto the mu opioid receptors, is a good strategy, right? That brings me a little bit to microdose initiations, right? This is not, still doesn't make it into official buprenorphine trainings. I think it's still relatively new, but people are doing this, right? And all of you may have heard of this, that everyone is doing some version of microdose initiations. They're becoming much more common. So my idea is really just to give the idea, right, that this is happening. The idea behind microdose initiation, the big difference compared to the traditional initiations, is that we're no longer requiring patients, if we take this approach, to go into withdrawals. So patients don't have to go into withdrawals. They can keep taking whatever the opioid they're taking, and at the same time, they start adding in tiny, tiny doses of buprenorphine into the regimen. The dose of buprenorphine goes up in a stepwise fashion over several days. So essentially, because of buprenorphine's high binding affinity at the mu opioid receptor, as the dose goes up, it's displacing some of the opioids that the patient is taking. So buprenorphine is basically allowing the patient to cross titrate. The medicine is doing the work for you, right, in many ways. So you're stepwise increasing buprenorphine until the dose is therapeutic, and then the patient stops whatever opioid they were taking. I find that this is particularly useful in patients with chronic pain or who are just not able to stop using their illicit opioids long enough to get onto buprenorphine. So for many of our patients, this is becoming a more important strategy. Doesn't require withdrawal prior to initiation, right? And the pre-existing opioid may be tapered or even stopped after the patient is at a therapeutic dose of buprenorphine. This is the basic idea. There are many different ways of doing it. This is kind of the standard idea where patients are starting. You can see how low, 0.25 milligrams of buprenorphine on day one, going to 0.25 twice a day, then 0.5 twice a day, 1 milligram twice a day. And really by week's end, they're building to 12 milligrams a day, and thereafter tapering off the opioid. So for the first 7 days, even if as they're adding in the buprenorphine, they're continuing to take their opioid, right? Some other slides, maintenance dosing. FDA actually at this point does have it lowered down to 24. Most insurances will only cover up to 24, but there is new data showing that patients might benefit at 24 and even up to 32. In fact, there are some national studies going on right now. They're testing to see whether patients might do better at 32 milligrams as opposed to 16 milligrams of buprenorphine, right? Duration of prescription. How long a prescription you provide? I think it's tied into how the patient is doing, and it can go both ways. And we have that discussion with our patients that it's not a punishment or reward, but really we want to match the frequency and the intensity of monitoring to how you're doing, right? So it's a negotiation. We generally start at weekly scripts, building up to monthly or monthly with refills as patients stabilize, as they do well. I think diversion management, we have a whole other talk on it, so I won't spend too much time, but really important that we're monitoring UDS screens, prescription drug monitoring programs, talking about safe storage, lock boxes, as well as considering doing kind of random 48-hour callbacks occasionally to patients. This one's HPSO stands for high potency synthetic opioids. By that really, I mean fentanyl and fentanyl analogs that are everywhere, right? So the idea is that actually, if you look at the studies, most patients are continuing to do well, even with these synthetic opioid inductions. But clinically, clinicians around the country are reporting that they're seeing more and more precipitated withdrawals when patients have been taking fentanyl and when they take buprenorphine, right? So those reports are coming in. Studies haven't consistently shown it. It is important to keep in mind that once started, buprenorphine seems to be about equally effective whether someone is taking illicit fentanyl or heroin. So our treatments still work, but we gotta help them get over that hump of getting started on the medicine, I think there are many theories out there as to why clinicians are seeing more precipitated withdrawals. There is some idea that fentanyl with chronic use seems to kind of be stored in tissue, released gradually. With chronic use, there may also be reduced renal clearance, right? So people are just having fentanyl hanging out in their system, and they're maybe going into precipitated withdrawals when they start. I don't know if that's the full answer. I think part of it is also maybe that patients are having also prolonged, protracted withdrawals because their baseline tolerance is so high. So the problem is that with fentanyl, what we're seeing is that the traditional way of doing it, 4 milligrams every 1 to 3 hours, it's kind of neither here nor there, right? So people are looking at different approaches. The one approach that we already talked about that people are taking is the microdose approach. The idea being that we're giving them so little buprenorphine that the patient doesn't even notice it until the buprenorphine is therapeutic, and then they can stop their fentanyl, right? Start low, go slow applies. Kind of low dose. People are doing different things. None of this has been empirically evaluated. I've included some reference things. I think in general, one thing that most experts are agreeing upon is that if you're going to do like a more traditional way of starting buprenorphine, where you're allowing the patients to go into withdrawals and then adding in buprenorphine, then waiting until the COW scale, the clinical opioid withdrawal scale, is at least 13 or 15. In other words, they're in moderate withdrawals before initiating the medicine is recommended, and also going low, right? So you can see that often patients are doing, or clinicians are doing 1 to 2 milligrams every couple of hours, so going even slower. I think if you do, again, a true microdose initiation, as in this slide here, then you don't have to worry about it because the patient is continuing to take fentanyl as you add in the buprenorphine. This was a study, a case report from 2020 that essentially used this slow approach to buprenorphine, with good results. Other approach is the opposite of it, the macrodose approach. And again, we've got a different presentation where we go into a lot more detail in this, where people are saying, let's give them enough buprenorphine to get them over this hump of withdrawals, get their mu receptors occupied, get that blockade effect of buprenorphine going, and we're good to go, right? And this was really initially studied by Mariani's group in New York, where they did a 2 to 3 day initiation. So they essentially started patients on buprenorphine. Within the second or third day, got them onto the buprenorphine injection, with the idea that the initiation is complete. More recently, they will also publish data case series of a 1 day initiation. So these are all participants, patients who were using illicit fentanyl. On day 1, the patients were built up to 24 milligrams of buprenorphine and then given the sublocade injection, which again releases quite a bit of buprenorphine into the system over the first couple of days, allowing us to achieve high blood levels. So they did this with, and had good results. So I think this is a good way to go. I think the big practical barrier to a macrodose initiation with the aid of an injection is, again, it's so hard to obtain the injection right now. It's patient specific. So if a patient comes in needing to start buprenorphine, I can't simply use this strategy because I don't have an injection for that patient. And I think for me, at least, that's what has limited the macrodose approach. Maybe if the injections become more readily available, they're easier to obtain, then I think this may become a much more viable approach clinically for our patients. Finally, a little bit on withdrawal, how long to go on maintenance. We've talked a lot about this. Keep in mind that even patients who've done well for a long time, following taper, following withdrawal, relapse rates, I think, are unacceptably high, right? 6 months relapse rates for our patients, exceed and approach, and in some cases exceed 90%, right? So really think about, why am I tapering the patient as opposed to putting them on maintenance treatment, right? That's the key question, right? It's got to be a decision made by the patient in a truly informed patient sense. Make sure the patient understands the risks of a taper, document that, carry out the taper, stretch it out for as long as possible. I ask my patients, how long do I have? And stretch it out, because the slower you go with the taper, the more comfortable the patient will be. And make sure they have naloxone. Make sure that you're keeping kind of the door open So if the patient changes their mind, wishes to go into maintenance treatment, that option is available to them, that you kept your door open, that you can re-engage the patient. In general, I tell my patients that, continue the maintenance for as long as it benefits you, right? I do have many patients who opt to taper off after a while and successfully are able to do so. And when I think about those patients, these are the things they have in common. They initiated going off the buprenorphine until their functional goals were met. They had more stable social networks, right? Their lives were just in a better place. And then doing it at their own pace while staying engaged in treatment, in therapy, in mutual support groups, whatever may work for the patient. And lastly, consider switching them over to the long-acting naltrexone, for a little while after they've tapered off of the buprenorphine as a safety net, while the patients build up their coping mechanisms, et cetera, right? So I'll end here. I'm 1 minute late.